So we have seen so far what are the effectiveness, what are the activity which this drug will be able to show. So these are the effects we have seen. This was the table. I told you that this was what I was expecting, and this is how the treatment is showing effects with various drugs. Only this much drugs are available therapeutically. The other supportive therapies are also there. Example of this is omega-3 fatty acids, and it shows that it can cause good reduction when omega-3 fatty acid, that is 4 gram per day for 7 months, are given. So it can show around 46% reduction in triglycerides, 21% in cholesterol. Again, if we compare with the control, then in around 3 to 4 years we can see a good difference when we are giving around 1800 milligram of this omega-3 fatty acid, that is eicosapentaenoic acid, and that shows good effect, but it does not show much benefit, because only there is a 2% relative risk reduction, which is not very big, or which is not statistically significant. So low dose omega-3 fatty acid do not provide cardiovascular benefit if it is given less, that is 900 milligram per day. Higher doses are providing. Example, we have seen 1800 or 4 grams per day. So these are very high doses. But 900 milligram is very small dose, and it will not show any effect. Then diet and reinfarction diet, in that it has tried, and it was shown that there was a reduction in the mortality. Again, this reduction is there. It is not very big, but yes, it can cause with initiation of this omega-3 fatty acids. Then this GIST trial was there. When it was given around 1 gram this polyunsaturated fatty acid, that is omega-3 unsaturated acid with vitamin A, for 3.5 years, and it has reduced mortality, but it was not very big, but yes, it is effective. It is causing it. Then next in this is it does not provide following MI in those which are having high utilization risk reducing therapy. So here dose was comparatively low, and therefore it was not effective. If we see the risk assessment with this having more than 2 risk factors and 10 years this coronary heart disease risk, so we can see that as the risk factor increases, the risk increases, and point wise 10, 20 if we say, so it increases, and in manifold. So this is very important. So the main aim should be reduction in the risk. There is one online calculator is available, that is known as a Framingham risk score online calculator. One can go on this site and put age, gender, male or female, what is total cholesterol level pounds, HDL cholesterol pound, if smoker, yes, systolic blood pressure, how much it is, whether any current medication is going on, yes or no, and on that basis it can show you the 10-year risk. You can try it at your level. Okay, you put it in Google search, that is Framingham risk score on the online calculator, that is calculated, that is from National Cholesterol Education Program. So that is doing it, and it is interesting one. Even it can be informed to other people also that it can be done. So this shows how these risk calculations are there for men. If age is 20 to this one 34, 35 to 90, see initially you will find the score is minus, because they are having comparatively less risk. as 40 to 44 age group is 0, and then with age the number of points are increasing. Okay, then what is the HDL? What is the level HDL? If HDL is greater than, then -1, 50 to 59, which is a normal one, is 0, 40 to 49 is 1, less than 42 will be adding smoking, non-smoker, smoker, and its age wise again calculation will be done. Then what is the systolic blood pressure? What will be the total cholesterol points? So on that basis all these points will be there, and sum of point will be there, that is on the basis of age, on the basis of HDL level, on the basis of systolic blood pressure, smoking pattern, total points. And then we can have like that, if the point total is 0 or less than 0, 10 risk is 1%. Then as the point grows, if it is more than 17% with maximum 1, then 10 risk is more than 30%. So like that we are calculating risk, and this is very important. So this hyperlipidemia is very important in that. In same way it is done for female. There is one more such risk calculation online score is there, that is known as a Renault risk score. Almost same things are added into that. What is gender, what is age, whether smoke or not, what is systolic blood pressure, what is total cholesterol, HDL, how much, and one more parameter is added, that is known as a high sensitivity CRP, that is C-reactive proteins. These are the diagnostic features. If they increases, then these people have more chances of atherosclerosis. And then one more pattern is added, whether genetic inheritance is there, mother or father had a heart attack or any such consequences, then you can calculate. So it adds two important things into it. Now what are the treatment plan and this atherosclerosis treatment plan for making LDL-C goal and cut point for drug therapy? So the patient which are having high risk, we have seen the risk factor calculation from Framingham studies. So the high risk patients, LDL-C goal should be less than 100 milligram. We have seen already goal setting, we have seen long back on the basis of various risk factors. So initially what should be this lipid levels, that is total cholesterol one, that it should be if it is greater than 100, then consider drug therapy and try to make it less than 100 milligram per dl in that. If it is moderately high risk, then instead of 100 milligram which was decided earlier, actually optionally we can keep anything between 70 to 100. Here we have range in moderately risk, that is around 100 to 130, and accordingly go for drug treatments, including the other therapy, that is dietary and other therapies. Then moderate risk, there are more than 2 risk factors, and 10 risk score is around less than 10%. Then in that cases go for this 130 milligram activity, and consider drug therapy only if it is greater than 160 mg per dl. Okay. Then lower risk, those who are having risk 0 to 1, having minimum risk factors, then even less than 160 is okay, appropriate, and if it goes beyond 190, then start the treatment, otherwise there is no need. So when you are starting treatment, it is clear. In high risk patient, even if it is 100, we are starting treatment. In moderately risk, even if it is 130 milligram, we are starting treatment. Okay. In moderately risk, where 10 risk is around less than, even if it is 160, we are increasing every time. Why? Because the number of risk factor otherwise are going less. So if risk factor increases, then we are bringing down the goal of lipid level. So other lipoprotein level accordingly we can go for, that is it should be, total cholesterol should be less than 200. These are 3 criteria, color wise you can remember: high risk, moderate risk, green color, then this gray color, then this orange color, and the bluish color. So these are the 4 color for high risk, moderate risk, and lower risk. Similarly, we have this, and if it is there, go for various activities and go treat accordingly whatsoever colors are there. Now what we are doing, primary prevention, we have discussed it earlier also. The lipid should be measured at least annually and more than often if needed to achieve goals. In adult less than 40 years of age and having low risk lipid values, lipid assessment may be repeated every 2 years. Lifestyle modification deserves primary emphasis for all individuals. Patient should focus on the reduction of saturated fat and cholesterol intake, weight loss, increase the dietary fiber and physical activity, and this if we already seen earlier during hypertension also DASH diet. Like similarly we can have diet control where the lipid intake will be lesser. Those which are having age greater than 40 years of age, then our goal is changing accordingly. We are going for, because risk factor wise it is increasing, and then we are trying to make it less than 100. Those which are less than 40 years without any cardiovascular disease but increased risk of cardiovascular diseases, either by clinical judgment, by risk calculation, LDL goal should be around 100 milligram per DL, and LD's lowering drugs should be considered if lifestyle changes do not achieve the cholesterol levels. So this should be the treatment accordingly, whatsoever levels are there, and you go for each treatment. Then there are 2 different agencies, that is American Heart Association and American Association for Diabetic People, that is American Diabetic Association. They give some different one in case of diabetes mellitus. The American Heart Association says that if patient having triglyceride level 200, 499, non-HDL-C goal is less than 130, and secondary target of triglycerides are greater than 500, therapeutic option includes fibrate or niacin before LDL-C lowering therapy. So first immediately you should go for reduction in the triglyceride, and niacin is the best drug for that. While the ADA suggests that lowering triglyceride to less than 150 DL and increase the HDL to 40 milligram, in women you make it higher, that is HDL-C goal 10 milligram higher, that is greater than 50 milligram should be considered. So here ADA give more stress on HDL level while it gives to triglyceride, AHA and LDL. So go for again lifestyle modification, reduction of the saturated fat, trans fat, cholesterol intake, increase omega-3 fatty acids, go for viscous fibers, plant stanols, sterols, and try for weight loss if possible, and go for increased physical activity should be recommended to improve the lipid profile. Then for diabetes, primary and secondary prevention, statin therapy should be added to lifestyle therapy regardless of baseline lipid level, particularly those who are having over cardiovascular disease and without cardiovascular disease who are over the age of 40 years and have more than one other cardiovascular disease risk factors. So in first case there were diseases, maybe heart failure, arrhythmia, etc., some diseases there. In second is, although there is no disease but there are risk factors for cardiovascular diseases like smoking, alcohol, nicotine, obesity, hyperlipidemia, etc. So accordingly we are going for treatment in different ways. So the patient which are lower risk, that is without any cardiovascular disease and age less than 40 years, statin therapy should be considered in addition to lifestyle therapy monitoring. And the LDL, if it remains greater than 100 milligram, or those having multiple cardiovascular disease risk factors. Then next is for primary and secondary prevention, individual without any severe disease, cardiovascular disease, Primary goal of LDL-C should be less than 100 milligram. Individual having cardiovascular diseases, then our LDL should be reduced to 70 milligram per DL. And if the drug is treated patient do not reach in the above target maximal tolerated statin therapy should be given. A reduction in the LDL-C of approximately 30 to 30%, 40% from the baseline is tried to achieve as a additional or alternative therapeutic goal. Triglyceride levels less than 150 milligram per DL and HDL-C should be greater than 40 milligram per DL. In men and in female it should be 50 ml. 50 mg in women they are desirable. LDL-C targeted statin therapy remains preferred therapy. So LDL is always taken care of. Most important, if it is happening during pregnancy, what should be done? So statin therapy is contraindicated during pregnancy. This is important. And during diabetes mellitus, what we are doing or what we have already seen that we are trying to reduce triglyceride level to 150 and we are increasing HDL-C level. Then these targets are there, but LDL targeted statin therapy remains the preferred strategy again, because statin are important and they control the LDL level and it is important. Again, if targets are not reached on the maximal tolerated doses of statin, combination of therapy using statin and other lipid lowering agents may be considered to achieve the lipid targets. But it has not been evaluated in outcome studies and means if we say the level of evidence in that case for combination is less, but yes, statin are most powerful one. So let us have the glimpse of it. Cholesterol management recommendation. So for secondary prevention, lipid profile should be established in all patients. For hospitalized or lipid lowering therapy should be recommended. Below should be initiated before discharge. First thing is lifestyle modification, including daily physical activity, weight management. They are strongly recommended. Dietary therapy of all patients should include reduced intake of saturated fat, trans fatty acid should be reduced, and cholesterol, dietary cholesterol should be reduced. So it should be reduced less than 200 milligram per day. So from expert dietitian, the diet chart should be made and accordingly it should be given. This is very, very essential. If you will see that the class of recommendation is 1 and the level of evidence is B, that is good one. Then for secondary prevention, what are other recommendations? See, you can see that class of recommendation is 1 and level of this is A, level of evidences is. So in that case, the therapeutic lifestyle changes. Statin therapy should be prescribed in absence of contraindication. So statin is the first line treatment. If there are some contraindication, example in pregnancy we are not giving, or some adverse reaction are there, example muscular problems are there, it is biggest problem, rhabdomyolysis or myopathies are there, so in that case it is not given. So these are contraindication. Then in adequate doses of statin should be used that reduces LDL-C less than 100 milligram and achieve at least 30% lowering of LDL-C levels. So this is good way. Again, recommendation wise it is topmost recommendation, and the level of evidence is C in that case. That means it is not a randomized clinical study. Then next is patient who are having triglycerides more than 200 mg per dl should be treated with statins to lower non-HDL-C to this make it to around LDL-C around 130. So this is another way. Then secondary prevention wise, triglyceride which is having more than 500 mg per dl should be started on fibrate therapy in addition to statin therapy to prevent acute pancreatitis, because if we do not pay attention towards triglyceride levels and we only try to reduce LDL, then it can result, it can affect the pancreatitis. So simultaneously we should try to bring down triglycerides also. If the treatment with the statin, including trials of higher dose statins and higher potency statin, does not achieve the goal selected for a patient, intensification of LDL lowering drug therapy with the bile side sequestrant or niacin is added. Now when we have, so far we have done two things. We have added statin plus fibrate or fibrates, and if it is not there, then we can add the another drug, that is bile acid sequestrants or niacin is added along with the statin. So statin always remain the first line treatment. For the patient who do not tolerate statin, LDL-C lowering therapy with bile acid sequestrant and or niacin is reasonable. So where patients cannot tolerate statin, we can use either this bile acid sequestrants or niacin. Then lastly, secondary prevention. We should treat high-risk patient with statin therapy to lower LDL-C to less than 70 milligram. So again, this is important in patients who are at very risk and who have triglyceride level more than 200 milligram per DL and non-HDL-C goal of less than 100 is reasonable. Use of ezetimibe may be considered for the patient who do not tolerate the higher dose of statin, bile acid sequestrant or niacin. Then we can go for the next drug of choice is ezetimibe. And then secondary prevention, the patient who continue to have elevated non-HDL, non-HDL means except HDL, various cholesterol, that is total cholesterol or LDL cholesterol. While adequate statin therapy, they consider the niacin or fibrate therapy. For all patients, it may be reasonable to recommend omega-3 fatty acid from fish or fish oil capsules, and minimum dose should be 1 gram per day to prevent the cardiovascular risk or to reduce the risk of cardiovascular diseases. So this is how we completed. We have finished the cholesterol or hyperlipidemic drugs. The important fact, we have seen that in various conditions, depending on the risk factors, we are having different set of goals. That is where the risk is very high, number of risk factors are more, maybe age, then hypertension, smoking, etc., family history. In that cases, we are reducing the goal, that is our goal to this one maintain is it starts with 70 mg per DL of this LDL, and if there are minimal risk factors, then we can allow the patient to have 130 milligram per DL LDL. So this is very important. For control, the first line treatment is always statin. If it is either contraindicated or is not recommended, then we shall be going for addition of other drugs like fibric acid, that is fenofibrate, etc., or then we'll go for this bile acid sequestrant or niacin. So this is how these are various recommendations which are made, and here we finish hyperlipidemia. So as per my this one, we have finished the cardiovascular system. Just let me tell you what is remaining. So you can see this yellow colored portion we have finished. If you have any difficulties or if you feel something is remaining, you can just remind me, you can inform me. So in pharmacotherapeutics, we have seen hypertension, various guidelines. Example are JNC7, JNC8 guidelines. Then we have seen CCF, congestive cardiac failure. We have seen two important guidelines into it, that is ACC and Newark Heart Association, NYHA guidelines. We have seen angina pectoris treatments, and again AHA, that is American Heart Association, ACC guidelines we have seen. Myocardial infarction also we have seen AHA, ACC guidelines. Hyperlipidemia we have just finished, and arrhythmias. So we have finished all these important electrophysiology of heart already we have discussed during this arrhythmia during we studied in pharmacology. During that also I ask you to refer Tortora and go through it. And during arrhythmias we have discussed it, what are various things related to electrophysiology, how this physiology is important, how this electrical conduction takes place, and how it is related with the cardiac cycle, how the ECG changes takes place, how conduction takes place from SN node, AV node, etc. So everything, that is all electrical condition that we have studied. So you will suggest me what next chapter you want to have. As I told you, we shall go for the next topic from the CNS, which is remaining. I have already given you my previous videos. I don't know how many of you have seen. So please go through these videos before we go for the next class, so that nobody, I have not seen your responses so far. I have many times told that what kind of topic you want after this, what topic you will like to study, what topic you will be having before, or you will get it revised before you are coming for the therapeutics or pharmacology class. So I repeat, if you do it, it's good. Second thing is, as I told you earlier most probably, but that the college has planned sessional examination in next few days. The official notification will be circulated once it is there. Then in that case you suggest me syllabus, because so far in pharmacotherapeutics we have got less syllabus, only cardiovascular system. We shall try to cover one or other small topic after that, so that it will be easy for you to understand. As per my knowledge, endocrine system you have studied in pharmacology, Navle sir has taught you. Respiratory I have taught you here. So what's the topic you feel, maybe respiratory, endocrine, or ophthalmology, or any other topic like pediatric, geriatric, pregnancy, lactation, or rational drug, whatsoever you feel you should have next, you can let me know. Please go through it and tell me. So cardiovascular system plus some more part will be there. Already I have, as I told you, CNS has been given to you. You go through the CNS. If you have any difficulties, have you gone through Google Classroom? Have you seen the CNS into it? Okay. So you can, and if you have any difficulty